Important question here, why we have to do an MRI before searching for the breast cancer, and when will be the proper time?
So it's a very good question with a fight in the international literature about it, because we see. So the operative evaluation is one of the most interesting topics concerning MRI local staging. About dimension, multifocal multicentricity, sequence contralateral, lesion and surround tissue relationship, we see that each MRI is much better than traditional imaging. The dimension of the lesion, in a lesion dense like this one, we can pulp the lesion, but it's difficult to measure it with ultrasound because it's too big, and also with mammography, it's easily to measure the lesion with MRI. In this case, we see microclassification, there is the lesion. With MRI, we can easily dimension the lesion. We did this study years ago with the Italian Society of Radiology with a factory of contrast media, and we evaluated all the about 100 patients, 188 malignant foci after mastectomy to evaluate the sensitivity of MRI versus mammography, and we confirmed at that time that the sensitivity was higher than the one of mammography. And also MRI is better in dimensioning the lesion if there is no concordance between mammography and ultrasonography, as in this case where the lesion seems to be bigger at the mammography than at the ultrasonography. We can really define the dimension of the lesion. Multifocality, multicentricity, multicentricity, and bilateral lesion. A case with small cancer on the right side after the MRI before treatment, we found another cancer in the other side, not seen at the previous mammography. Again, I already showed this image, that's a recent image, where we found a big lesion in a young patient, and after MRI we discovered that the lesion was not alone, but what is a real multi-eccentric cancer. We know from the literature that MRI is better also in the evaluation of the dimension of extended intraductal component. You know that often with the invasive cancer there is an intraductal component, and this numerous studies demonstrated that MRI can evaluate, can dimension better also DCS. This is an example. This is the invasive cancer, and this is the intraductal component going to the nipple. So the surgeon knows from the radiologist that the cancer is bigger, and maybe it could be better to proceed to mastectomy. And also in evaluating the surrounding tissue, MRI could be better because it's difficult when we found the lesion with ultrasonography to see the relationship with the muscle, and more difficult again with mammography, is quite impossible. So it's easier to see that there is a micro infiltration of the muscle in this case. We know that there are contralateral cancer, and they demonstrated, the literature demonstrated that the range is around 3% of the cases of cancer, as also a cancer in contralateral breast, and MRI demonstrated a negative predictive value of 99%. So just to show that in the guidelines that of the USOPI from 2008, they suggested to use MRI to screen the contralateral breast in case of breast cancer. But just to go on, in invasive globular carcinoma, the group of Carla Boetes and Mann demonstrated demonstrated that MRI is more sensitive in the invasive lobular carcinoma. You know, for radiologists, it's always a problem. Sometimes the lobular carcinoma is palpable, but we're not able to see it at mammography, and sometimes also at sonography because it's very diffuse. It has a spatial morphology. It's easier to see it by MRI, and they demonstrated it and demonstrated that thanks to MRI, the operation rate was less than patient who didn't have MRI before, at the same for mastectomies. Less mastectomy, 48% after MRI, 59 with no MRI. So MRI can be used. So in concluding, we can say that MRI is better in dimensioning, in evaluating multifocal, multicentricity, contralateral cancer, BCIS, extended intralateral component, relationship with surround tissue immediately post-operative evaluation. But there are some questions. So we started with a lot of enthusiasm years ago, but now the first question is, can MRI change the treatment? And the answer is yes, it can change the treatment, but not always in the right way. There is this meta-analysis from 2008 from Usami demonstrating that it's correct in about 11% of the cases, but it's incorrect in about 5% to 6% of the cases. So we could proceed to mastectomy that could be avoided just only because of the MRI image. So this author doesn't like absolutely MRI. He wrote that increases number of identified lesion, does not improve surgery, modifies surgery, that becomes more extensive, can increase ipsilateral mastectomies, contralateral prophylactic mastectomies, increase WhatsApp, and delays surgery. And again, radiotherapy reduces recurrences, so we don't need something more than traditional imaging. After radiotherapy, the recurrence rate is only 4%, so we don't need others. And radiotherapy controls occult disease. MRI does not improve the outcome. And unfortunately, in 2010, on The Lancet, they published this work. So the first question was, does MRI can change the treatment? The answer was yes. But does this change modify the outcome? Is the big question on the carpet at the moment. And this study, the Comice study, evaluated 1,600 patients, 800 with MRI, 800 with no MRI, that underwent surgery to evaluate the reoperation rate. It's not a real outcome, but it's something that is a preliminary outcome. But the rate was the same, 20%. And they changed the clinical management in 70% of the cases, and they proceed to avoid all mastectomy in 30% of the cases of mastectomies. So they concluded that additional lesions not necessarily means improve clinical outcomes, and preoperative MRI can only be a more extensive way for surgery. But they had, as I told you, a big fight on the literature, and Elizabeth Morris from the Memorial of New York wrote a lot of critics on this paper. She wrote that they needed 6 years in 45 hospitals, that there are a lot of hospitals. They didn't have MRI-guided biopsy possibility, no MRI localization, 28% of mastectomy were without confirmation, pathological confirmation. That means that the radiologist saw an image suspicious at MRI and the patient went to mastectomy. That is not something common at the moment. I think it's something very close to the malpractice. A large number of recruiters, One patient for month was operated. 86 patients were recruited by surgeon, operated 10 patients in 6 years. So it means that all the radiologists and the surgeon were not working in a team, were not specialized in breast surgery or radiology. And this is something like a picture of the situation in England and in Italy, but I think it's not good for a scientific paper because you demonstrated that it's not working, but not in the scientific, in a real scientific way, a real scientific study. I don't go on in the other critics because otherwise I don't have time to see other important thing. So there is a lack of demonstration of beneficial impact of patient outcome, and the Osobi wrote is so far unclear whether breast MRI contributes to better control of the disease or survival of all patients with diagnosed breast cancer. The Americans ACR remains to be conclusively shown that these adverse recurrence rates are relative to modern surgery, radiation and systemic therapy, and so on. So at the moment we don't know really. So we know something, that we know that we don't have to perform MRI to all the patients who are candidates to surgery. We can stratify the population and decide when MRI can be useful now. For instance, in nipple-sparing mastectomy, we know that the negative predictive value of MRIs is higher than mammography, and also in PBI, that is partial breast irradiation. See, if you want to proceed, we need that the lesion has to be one only, and we can exclude other lesions only with MRI at the moment. So if we perform MRI, the 5% or more of the candidates will not be eligible for the PBI. And this again, PBI, this is an example to show you nipple-sparing mastectomy. You can very well calculate the distance from the nipple and the lesion. That could be very useful. Eosoma indication. They suggest to use MRI in invasive lobular cancer before treatment, before surgery, invasive lobular cancer, in high risk for breast cancer. A patient under 60, if there is a discrepancy in size more than 1 centimeter between mammography and ultrasonography, in patient eligible for PBI on the basis of clinical evaluation and conventional imaging. Other indication for preoperative MRI may be considered, for instance, Paget disease is the same case I showed you before, in invasive cancer and Paget disease, multifocal, multicentric or bilateral cancer at conventional imaging to have a better evaluation of all the breast and the contralateral breast, skin or nipple-sparing mastectomy outside the iris setting, and pathologically positive margins after breast-conserving surgery. One good thing is that you can perform MRI immediately after surgery if you don't find a lesion, or if the margins are positive, the patient can go straight to the MRI and you can have a lot of information that you can't have with ultrasound and mammography immediately after surgery. Again, a recommendation, breast MRI is recommended. They recommend to inform the patient. Women with breast cancer should be informed of the risks and benefits of preoperative MRI. Results of preoperative MRI should be interpreted with clinical evaluation, mammography and ultrasonography. Lesions MRI only require MR guidance for needle biopsy localization. A total treatment delay due to MRI has to be no longer than 1 month. And the possible changes in therapeutic planning resulting from preoperative MRI has to be decided by a multidisciplinary team. So the radiologist can work alone. Take-home points, preoperative MRI is one of the oldest controversial breast cancer care today. Surely the most important in breast imaging, the ability of MRI to detect otherwise occult cancer foci is completely demonstrated. The MRI impact on recession rate is not clear. The impact of on free disease and overall survival is unknown, and radiologists should cooperate with breast care team for the best use of preoperative MRI. And we need a well-designed research. And we are starting with a USOBI in this topic, with a MIPA study that is an overworld study that will evaluate 1,000 of patients with that candidate to surgery with a previous breast MRI or nothing. Thank you.
Thank you.
And now the last topic has to be to Professor Scaperotta. I'm the chief of Professor Scaperotta. So usually is the young that speak for the old. In this case, the old will speak for the young, because
let's say our next presentation about MRI evaluation of reconstructed breast is supposed to be by Professor Gianfranco. He's here with us. He didn't go to the pyramids, but he prefers and he likes that Professor Pietro continue with the thing. Yeah.
So you can imagine who works at home. Anyway.
So this will be his last presentation, and we have some questions for him before our two Egyptian queens of breast imaging giving us their lectures.
Yes, I promise this is my last one. Tomorrow, the last one. So detection in recommended breast. You know that mammography can have a problem in patients with reconstructed breast. We can have architectural distortion, problem of density, calcification. We can compress the breast, and we can have a radiopath shadow cast by implant. But literature demonstrated that with submammary implants, we lose 37% of the breast image, and with submuscular implants, we lose the 17% of the image of the glandular tissue. So implants dramatically reduce the sensitivity of mammography. We can use spatial displacement as the Ekron displacement, spatial technique, but they are not enough. This is an example. Mammography, you see that in this case, that it's retro muscle, retropectoral. This is retroglandular. In this case, you lose the most part of the breast. Effect of implants on disease. This is a big question because often patients ask for it. But if there is, the literature says that there is no difference in breast cancer risk. The breast cancer risk, the breast cancer mortality is below the expected, and the delayed detection due to mammography is not real because they have the same stage at diagnosis than people, women without implants, and the same tumor size, the same post-breast cancer survival. So, I love ultrasound as Gianfranco, and I think it's a very good technique to evaluate the augmented breast. There are few studies and no randomized controlled trials. It can detect cancer not seen at mammography, as we know, with a 91% of accuracy instead of 74% of mammography. It's not influenced by implants. It's useful also in asymptomatic, as in dense breast, and is useful in symptomatic because it's perfect to explain palpable findings and can explain mammographic images. It's difficult to evaluate behind the implants, as I showed you before, and I will show again. This is an example. You see the implant, this is the glandular tissue, and the implant. This implant is behind the muscle that you can easily recognize here. This is in front of the muscle behind the glandular tissue. Again, two different aspects of implant. MRI is not influenced by implants. The implants do not reduce sensitivity of MRI. Is the first choice in high risk. They detect all tissue surrounding implants. One of the advantages of the MRI is that it's multiplanar, so we can acquire the imaging in axial view, and then we can look it in sagittal and in coronal view. And we can study prosthesis without contrast media. This is the same image I showed before. You can easily see behind the implant. This is a case with a cancer. This is the implant. This is a subtracted image, a very old image. And here we can easily recognize the cancer. In this case, we understood that something was wrong at mammography, but you can see very well the extension of the disease over the prosthesis. And detection of implants after mastectomy. The clinical evaluation is routinely performed, mammography is not routinely performed, sometimes in asymptomatic, always in symptomatic, and MRI is not useful. Detection in contralateral breast after mastoplasty and mastopexy. Mammography, over 30, routinely performed yearly. And we can have problem with architectural distortion, calcification, and opacity because of the mastoplasty or mastopexy. Ultrasonography is complementary to clinical evaluation mammography. It's useful to recognize liquid collection, hypoechoic areas, and distortions. And MRI is useful, as I told you, in high-risk patients in equivocal findings at mammography and ultrasonography, and when it's difficult to biopsy and receive. The complication in breast implants, we have early complications: breast pain, hematoma, seroma, infection, Mondor's syndrome. Late complications, capsular contracture, gel bleeding, rupture, malpositioning, ptosis, implant visible, granuloma, and calcification we see. Mammography can evaluate extracapsular rupture and calcifications and capsular contracture, but it's not the best way to evaluate those complications. It would be better to evaluate with ultrasound. That, in my opinion, is the first choice imaging in case of symptomatic prosthesis. You can recognize extracapsular rupture, gel bleeding, hematoma, seroma infection, also the Mondor using a color Doppler, capsular contracture, implant. When they are palpable, I show you sometimes the patient come because they find a nodule. It's simply the prosthesis that you can feel, you can palp, and granuloma. Complication well seen at MRI, but I prefer to show you some images. This is a capsular contracture. Usually it's a clinical diagnosis, but you can see the increase of the capsular thickness, and at MRI you can see the change in morphology. There was usually this is the normal morphology of the implant. The morphology is round morphology, and it corresponded to the clinical data. And it was a case of capsular contracture. In this case, you can measure in a high thickness of the capsular tissue. There is something that I like, is the gel bleeding. There is not the rupture of the prosthesis, but the silicone, the gel, comes out from the prosthesis, and it can go straight to the lymph node of the axilla. You can see images like this. Those are lymph nodes with silicone inside. When you see it once in your life, you recognize it forever because it's very easy. And sometimes you don't see, you have a prosthesis like this, that's perfect, but you find silicone in the lymph nodes, and it means that it's time to change prosthesis. This is the same case at the MRI. You see the silicone in the axilla here. Again, fracture. You see silicone outside the prosthesis very well at MRI. Again, when you have an intracapsular rupture, you see that if you remind the images I showed you before, this is the aspect of silicone outside the wall, the silicone envelope. This is the spaghetti sign. From the Americans, they like to say spaghetti sign is the wall floating into the silicone, and this is the salad oil pattern because water and silicone are mixed because of the rupture of one of the internal shell. Again, intracapsular rupture, you see silicone outside, also at mammography, silicone outside the capsular tissue at ultrasonography and at MRI. Extracapsular rupture, sometimes you can find silicone everywhere. This is a case, the terrible case. This is all silicone dropping down the axilla, and it was palpable under the skin. It was very there. Then you can look at the position very well thanks to the MRI. In this case, there is a ptosis of the prosthesis that is going down into the muscle, and here there is an herniation of the prosthesis. And again, this is a case of a patient who came the first time for a control after a mastectomy with this prosthesis, and then he started to say that my prosthesis, my implant changed the morphology. The surgeon didn't believe her, and no one believed her. They say it's impossible. This is the MRI after 1 year, and she was right. I mean, the prosthesis turned and there to change it. Again, palpable nodules. In this case, the prosthesis become very close to the skin, and you can palpate them. Sometimes they come because of the nodule. It's not a nodule, and just the profile of the prosthesis. You can see it very well also with ultrasonography. It's very easy to put the finger on the nodule and to put your probe and see that there is not a nodule, but only the prosthesis wall. Again, you can have granuloma because of silicone outside. It's very similar, the image, to the one of silicone into the lymph nodes. This could be palpable. And about interventional procedures, as I told you, as Gianfranco underlined before, ultrasound is the first choice to guide biopsy because it's a real-time procedure. And you have a lower risk of implant damage, it's fast and low cost. Mammostereotactic MRI guidance are possible, but you don't see the implant during the procedure. So you have to evaluate the risk to damage implants. If the risk, there is a high risk, but the lesion seems to be a real cancer, you can proceed. Otherwise, in this case, it would be better if you evaluate with ultrasonography and mammography to proceed to MRI. If MRI is negative, you can wait. If a risk is start with cytology. So it's easier to work with a small needle, but it's not always true. So if you are not confident, you can start with cytology. It's very easy, as you can see in this image. You can go very straight to the implant without creating any damage. I mean, Gianfranco can do better. I mean, he's used to do also endostereotactic guidance. And Lieberman in the United States wrote a paper where she doesn't have any problem to biopsy also under MRI, also in presence of the implant. But I'm not so confident. Anyway, the indication to conclude the suggestion of the Eusoma, MRI in women with breast implants, implant integrity evaluation can be done with MRI and also breast cancer detection. Detect rupture in 78 to 89% of the cases. It's the most accurate technique in differentiating intracapsular from extracapsular rupture, assessing the extent of silicone leakage into the breast. So the recommendation in case of breast augmentation bronchoplastic reconstruction is not recommended in asymptomatic patients as a routine. Is recommended for high-risk groups. Is indicated in symptomatic patients if foundational imaging is negative or equivocal, and so on. But my suggestion is to try to solve your problem with ultrasonography before to go to MRI. Because sometimes after MRI, I'm not convinced about the rupture or so on, and I go back to the ultrasonography because I think sometimes it's easier. And so this is the message. Thank you for the attention.
Thank you very much, Professor Pietro, for the four presentations. Now we can have a few questions before we proceed to the next presentation. Anybody on the floor would like to ask Professor Pietro?
What about spectroscopy? So I think spectroscopy is a very good topic because it depends on which machine you have to work to perform MRI. Because in my experience, we had Philips in the previous hospital. Spectroscopy was not good. Whereas now they say we have another machine. I think it's Siemens, but they don't have any result with spectroscopy. And I think GE could be the best for spectroscopy, but it's not so easy because the literature is not in agreement. I believe at the moment that diffusion-weighted imaging is much better and easier to use because it's not time-consuming. In 2 minutes, you can acquire images in diffusion with diffusion sequences. And you have a panoramic view of both breasts instead of spectroscopy. Spectroscopy, you have to finish the examination, and then you have to look at one lesion and to measure the spectroscopy to acquire sequences on that area. And sometimes you have problem depending on the contrast video you use. Because I demonstrated that also the kind of contrast video you use can modify the spectrum of cornea. So it's a very interesting topic, but I don't think at the moment we can suggest to use it in a clinical way. I suggest that we started to use diffusion imaging in the clinical way. Also because I told you in 2 minutes you acquire the images, you put the images in the corner, and then at the end of the examination, if you need other information to characterize the lesion, you pick up your diffusion. It's a panoramic view of both breasts. You look at the lesion that is suspicious for you, and often you can solve the problem. And we did a presentation at RSNA, I think 2 years ago, demonstrated that diffusion imaging can be better than the curve of enhancement, because it's more specific. Yes, in our case it was 1.4, the ADC. Yes.
Question.
Okay, under 1.4 was malignant. Sorry.
Thank you.
when we follow up patients under neoadjuvant chemotherapy with MRI, which do you expect to see first, and which is the most reliable sign? Change in size, or change in signal in the intensity of the contrast uptake, or change in kinematics, or change in diffusion? Which is the most reliable, and what do you expect to see first?
So we expect everything, but I think Professor Abdelrazak will speak about this topic now. So I don't want to, maybe we could talk about after her presentation.
I just wanted your opinion. I know that
the opinion is that till now the reduction of the volume was one of the most interesting things. But we understood that also in this case diffusion can be very useful because it can predict the response, the effect of the chemotherapy. So it's under evaluation, but I think it will be very important in the future also because oncologists are using neoadjuvant chemotherapy much more than in the past. So the problem is to convince the oncologists because we know that the MRI is good from 10 years, since 10 years, but they never ask MRI to have an early evaluation of the effectiveness of the chemotherapy. So we have to talk to each other in a multi-centric department, the breast clinic.
I have another question. Which you depend on more, the time intensity curve or the morphology and signal intensity change for calling a malignancy?
Sorry, I can't. There is a noise coming.
For malignancy, diagnosis of malignancy, which you depend on more, the time intensity curve or morphology and signal intensity change?
So going to the tritesa, morphology is becoming more important. As I told at the beginning, we thought that the cure that was the new element because we were used to look at morphology with mammography and ultrasonography, and there was something new, the dynamic examination, the dynamic of the contrast enhancement. And we thought the curve could be more important than morphology. Now we went back, and morphology is becoming more important. We look very well at morphology. We try to have high resolution imaging because the curves are not so good as we thought at the beginning.
Yeah, well, this question, because I noticed that many of the cases coming for me to do a biopsy, and then I found that they are just normal tissue or fat necrosis, and they were calling most of those quick cases depending on the time intensity curve rather than morphology and signal intensity.
So I often see reports in Italy that they stress a lot of the curve, but the curve becomes. I don't know if I have an algorithm with me. There is an American an algorithm suggested from the Sloan Kettering, where they look at the morphology. If the morphology is going to malignancy, they go straight to biopsy. Otherwise, then use also the curve. But the curve is something that becomes after.
So one last question. It's my question. I'm more interested in the early detection of breast cancer in young generation, like from 25 to 35 years old. If you go to an MRI, you start with xvid, as we said, and you found speculated mass. Why you have to continue? Why I have to say I want to do a contrast enhanced, or I want to continue spectroscopy diffusion?
I have problem to hear because there is.
Okay, I say it again. You are doing MRI for you are doing MRI for young age from 25 to 75. She has breast, mammography, dense breast, nothing can see on it, so it was to MRI, and we found speculated mass on xvid. Do you like to continue, or do you stop at that level? go for biopsy, or you want to do contrast enhanced spectroscopy and diffusion and intervention pay more. But speculating if you feel something irregular margin or speculated margin, MRI and xvid2. For my experience, we can't stop and we go for histopathological evaluation.
That is a very good question because it could be the future. I mean, we are thinking, at the beginning we started saying, I think about 15 years ago, no contrast, no MRI. Now we are trying to go back also because we have to evaluate annually for screening the high risk and so on. And we are starting to evaluate images without contrast media. And we found that they could be very similar to mammography. And it's a cheapest examination, faster, and could be the future. And but I think in a clinical use, also if we see speculated mass, we prefer to go to perform the complete examination with contrast media. I mean, because we are used to, not because we thought could be better.
The tricky part of my question is that we have a lot of 0.2, 0.3 Tesla MRI all over the country here, and I'm sure in Europe the same. But if you say that we have only to rely on one Tesla, that means you cannot do this exam on a lot of patients.
Yes, also this was a topic that I loved it, because when they started to speak about contrast media in mammography, I thought in this way I can use a low Tesla MRI and have something that could be anyway better because it's a 3D image than mammography with contrast media. But I don't think there are studies demonstrating it. Because if I just have to see the lesion and then I try another way to characterize it, it could be a good way. But we have to test it. I don't think in literature they demonstrate. They try to demonstrate the opposite. They are going to 3 Tesla and 7 Tesla, but it's something that I find very interesting. We have to test. It could be interesting to test it also because the machine with a slow Tesla, with a low Tesla field are completely different than the machine that 10 years ago, then they started to say they are not used for.
Thank you very much.
I think in the dense breast, it won't make much difference if we see the T2 weighted images alone than the mammography. Because in the T2 weighted images without contrast, you might not detect the morphology of the lesion, so it's of no use. You will have a dense parenchyma and a dense lesion and a dark lesion, and it won't appear. It might be beneficial in a fatty breast, in which we might not need the MRI. In a fatty breast, the fat will appear white, the mass will appear dark, so we can detect the morphology even without contrast out there.
Yes, in a fatty breast, I did also biopsies without contrast media because there was only the cancer.
I think it's of no use to perform an MRI without contrast.
Yes.
Well, I say that my opinion is exit door, exit stair even is much better. Anyway, we have to move to the next presentation. Thank you very much, Professor Bieta, for all your information you give it to us today. Thank you very much. Now we're moving to our two distinguished lecturers. First, Professor Nakam Perezin. Her talk will be about evaluation of pathological complete response after neoadjuvant chemotherapy by MRI.
Thank you, Mr. Chairman, for the introduction. It's